So we're going to get started. Thank you guys for coming, non-APS people, APS people, thank you for coming. My name is Josh Falani. I run the marketing arm for Arizona Pain. We're excited to have you guys. I'm speaking to you two because they all know me on this side. So Dr. Carlson and Dr. McJunkin were the first physicians in the Southwest selected to perform this new procedure called DRG. So they're going to talk about that today. We're super excited and blessed to have them as a part of our staff, and they're going to come explain what the therapy is. But very revolutionary, and for the first time we're allowed to treat some pain that we couldn't treat before. So they're going to talk more about that. But thank you guys for coming. If you have any questions, you can ask these guys. So thank you.
Thank you, Josh. I appreciate it. Sorry, all the lights and everything, but we're actually getting this set up so we can have this for other doctors in the practice be able to access this and be able to learn about DRG stimulation. So all these cameras and lights we don't normally have, but we just thought it'd be helpful because we're actually Arizona Pain Specialists, and we're in several different locations. We're not just here in Arizona now. We're in Colorado, we're in Texas, we're in Florida. So a lot of other docs are interested and curious about the modality. Not that it makes me special or Dr. McJunkin, but we're really excited that we were selected by St. Jude Medical to be the first docs literally in this region to pioneer this modality. And kind of painting the landscape of why I think this is significant. Some people are like, well, is this another Me Too type of stimulation? Is this something that you're just trying to kind of throw some smoke and mirrors so we can get some more stim and whatnot? And I really don't think that. As far as pain management, we're the youngest specialty, first recognized by the American Board of Medical Specialties in 1993. And years ago, talking to my attendees, and I graduated in 2009, McJunkin in 2007. Years ago, we're talking probably early 2000s, maybe even late 2000s. A lot of times a patient would come in for low back pain, and it was almost kind of the go-to, well, I'll just get an epidural steroid injection. And that was just kind of, hey, sciatica, stenosis, we'll just see how they respond, put steroid in the area. And that was kind of the first thing that we'd go to. And then we sophisticated ourselves and did some research and learned more about the anatomy and what responded, what didn't respond. So we had Joe Fortin that looked at SI joint and sacroiliac joint being a source of pain. We had looking at the zygapophyseal joints and the facet joints being a source of pain as well. And cluneal nerves, so cluneal neuralgia. And so we became more sophisticated in looking at how we approach pain in the low back and what types of injections that we do as a pain specialist. And I want to be careful here. This is all in the context of doing the right thing for the patient at the right time. So of course this is assuming we've already exhausted medications over the counter and OMM and physical therapy and chiropractic care and more conservative things, and we've moved on to injections. And we found that we have to be careful in how we move forward looking at the low back and how we treat things. So we have to customize based on what we think the pathology is, physical exam, what the patient's telling us, maybe what imaging shows, and so we don't always go to epidural steroid injections. So for STEM, it's kind of been that up until recently. In Europe and Australia, there's been different types of stimulation that have been available. Actually, it's interesting, invented here in the U.S. and developed here in the U.S., but there's three types of stimulation that have really taken off, different than the type of stimulation that's been around. Just to kind of describe stimulation, it's been around since the late 1960s, developed by Sheely for chronic pain. It's actually for cancer patients. And then it just kind of had some ebbs and flows. It really started taking off in the late 1990s. And we saw it really begin to use for really failed back surgery syndrome, or the Medicare guidelines would say refractory pain of trunk and limb unresponsive to conservative treatment. And that's really morphed into what we feel is neuropathic pain, or as I got to be careful about neurologists in the room. My understanding of the changes that of having nociceptive pain, musculoskeletal pain, become chronic pain over time. You have the central sensitization and the different things that happen with the nervous system, where you have it develop into neuropathic pain. So we have these syndromes where there's direct nerve injury or maybe nociceptive musculoskeletal pain, or however it works with the nervous system. This chronic pain becomes neuropathic in certain cases, and we try spinal cord stimulation for these patients. And so we used to do stimulation really for all patients that had these refractory types of pain without surgically correctable lesions. And am I in the right spot here, Steve, so you can see the screen as well? So just let me know. And so we just say, okay, someone's had back surgery, someone's had neck surgery, someone's had maybe surgery of the abdomen or the foot. They've had CRPS, complex regional pain syndrome, or reflex sympathetic dystrophy. And we're going to try stimulation because they failed injections and other types of conservative things. And we'll just do really one type of stimulation. We might map out where we place the stimulation and where we get the stimulation over the area of pain. And let me kind of back up a little more, just as I don't want to assume anything here. But stimulation is that we stimulate the areas that the patient hurts with a different type of sensation. So what does that mean? So the best example I can give is that if someone hits their thumb, the first thing that we do is that we grab the thumb, we start to rub it. So what we're doing, we have the C fibers and the A delta fibers firing off the pain fibers, and we stimulate the A beta fibers, and we're kind of masking that pain, taking that painful sensation that the patient's feeling and exchanging it for a pleasant sensation in the patient's areas that they hurt. So that's what stimulation does, and stimulating the dorsal columns of the spine. So we would just say, okay, spinal cord stimulation for this patient with refractory pain. And now we become more sophisticated. We'll actually look at the type of stimulation for the patient based on the pathology they have, specifically maybe in the area that they hurt or the type of pain that they have. And I would say real briefly, because I think I'm here to teach doctors, that high frequency stimulation with Nevro seems to have shown in the data, level 1 evidence actually, that it's been very helpful for axial back pain in patients that have surgery and some that have failed conservative treatments and that haven't had surgery. Burst stimulation is actually not available in the U.S. right now, but since again this is for physicians by physicians, I created these slides myself, and something that St. Jude gave me a deck for. But basically, burst stimulation has been wildly successful in Europe. It's a different type of stimulation where we feel it's going to help the low back and leg pain, so traditionally the sciatica type of pain. And then the reason why we're here tonight, DRG stimulation, is for focal types of pain, particularly patients with CRPS, complex regional pain syndrome, type 1, type 2, but really patients that have had maybe a nerve injury, they've had surgery, say a hip replaced, say they've had a hernia repair, they've had knees replaced, foot, ankle surgery, even abdominal pain, and there's possibly an identifiable nerve that's been injured, and they're having chronic pain because of it. And I'm going to talk about a level 1 evidence study that's just been recently presented at the Neuromodulation Society meeting here in December, and it's being worked on. We're hoping to get it published in I believe in JAMA or New England Journal of Medicine. I can't remember which one is really kind of entertaining us and wanted to accept this article, but they're excited about it because it really is groundbreaking information. So let's kind of just dive deep into this. Anything you wanted to add? I wanted to introduce Dr. McJunkin. He's also going to be talking about this. Is there anything else that you wanted to add before I dive into the lecture?
No.
Okay, so let's just talk about it. So I'm going to kind of back up a little bit here and just assume nothing and just addressing the CDC guidelines. Not that it makes me special, but I was one of the docs that helped develop the opioid prescribing guidelines for the state among about 100 other people, but there's 3 pain docs in particular that helped develop it. But we have a big problem here in Arizona with opioids being abused. We were number 6 in the country, age-related deaths. We think because of the opioid prescribing guidelines that we're about number 12, but still in that first quartile of deaths related to opioids. So this is an example we see almost all the time in our clinic, is that, here's a patient example. Doc, I'm missing work. I'm going to lose my job. Would you please help? Would you mind increasing my pain medications, my opioids? And I don't mean to be glib when I show this, but I don't know if you guys have ever seen this scenario in clinic, but it's uncanny how many times I feel that this happens where I lost my meds, the dog ate him, I got a funeral, I got a vacation to go to, and so it's just kind of funny. I'm not trying to put down patients with legitimate pain, but it's just really tough because we have a lot of diversion going on. Either patients are addicted to the medications or they're selling them, and we have to kind of tease out and be careful with this. So immediately when someone comes in, I'm not going to lie, I try not to do counter transfers, but I try not to think of this scenario, but I still think it's funny to put up there. And just kind of say, it's tough to navigate when we should write for an opioid, when we shouldn't. Next here. So after doing a thorough H&P, what would you do? Victoria, you're one of our pain PAs. What would you do? And this is kind of unfair because I'm kind of guessing what I'm thinking here, but what would you do in this scenario? You've done an H&P, and the patient's asking for more pain meds. What are just some simple things that you would think of? We talk about it every day, so I'm hoping that I'm throwing you a softball here.
No early refills on opioids.
So no early refills, that's definitely good. But even stepping back a little more, being more broad, I would ask the patient, hey, look, we need to do a chart review. We get medical records. This is actually considered by the osteopathic board, and she knows that. She does it all the time. The osteopathic board and the allopathic board, that we get medical records and we review them first. It's amazing to me how many times, and I review for both medical boards, it's amazing to me how many times I've seen doctors get censured because they don't simply ask for records and review them before starting to prescribe opioids. So we look at medical records, go ahead. And the patient's like, oh, okay, you get medical records, I'm fine. I don't need an increase. Would you just write for what I was on, doc? So let's go to the next slide. Let's try to take a quick sidestep. So there's increased risk with prescribing high-dose opioids for chronic non-cancer pain. This is a hot topic, obviously, because the CDC just came out with their prescribing guidelines for opioids, and really, it's kind of crazy. They're really saying, man, we don't think the evidence is really there. 39 studies for long-term chronic opioids. There's really no good evidence. So they're really kind of discouraging to not write for it. And they're saying, hey, look, in select cases maybe, but right now we don't know what to do. We just think right now you got to be careful in writing for any opioids in patients. I like, and this patient happens to be on 240 oral morphine equivalents per day. So in JAMA in 2011 showed a 7-fold increase in unintentional overdose deaths with oral morphine equivalents greater than 100 milligrams per day. And then Archives of Internal Medicine showed a 3-fold increase with deaths of oral morphine equivalents greater than 200 milligrams per day. And this doesn't even include low dose and all those issues, but this is a big problem. And so it's funny to me that one of the CDC stats is that from 1999 to 2014, there was 165,000 deaths related to opioid pain medications. I mean, what other procedure, what other medication would be allowed to still continue to exist on the market if there were that many deaths? And it just blows my mind how political opioids are. And don't get me wrong, I'm not trying to vilify docs that write for opioids. I do as a pain specialist. I'm not trying to put down patients that are on them. I have several patients that are on them. But it just raises the question, why are these still allowed and why are we still writing for so many of them? Go ahead and show the next slide. So you can see this huge increase in opioid-related deaths from those stats that I talked about. This huge uptake in opioids. Next slide. And this is just in 2010, Arizona, we were number 6 in the country, age-related deaths, 18 to 45 per 100,000 people. And so we're number 6 in deaths. The CDC came to us and said, look, we recommend you come out with opioid prescribing guidelines because if you don't, we're going to help you. And so we're like, well, we'll time out. We'll come out with guidelines. And so we did. We think, again, we're at 12 now, but it's still a big problem. Last year, actually 2014, we're still working on 2015 data, there are 372 deaths in Arizona related to opioids. So we have 165,000 deaths. We're having all these medications written for, and so we need to start thinking outside the box. Again, I'm not against patients getting opioids, but probably low dose and probably no dose if they're young. I don't know. I'm not a detective. I'm not a private eye, but there's a lot of diversion going on. I'm sure you guys know this, but morphine is one molecular structure different than heroin. 6-monoacetylmorphine is the only thing that separates morphine from heroin. So highly addictive, highly habit-forming. I make sure I tell all my patients, but let's get a little more granular with that. Let's talk about the endocrine risk with risk of high-dose opioids, not just high-dose, but even low-dose, but chronic use of opioids, like endocrine suppression. So pituitary hypothalamic axis suppression specifically of gonadotropins, testosterone, decreased sexual function, increased fatigue, decreased muscle strength. It could affect thyroid hormones, and there's discussion that happened to patients. The thing that's scary, though, it's been documented. Anesthesiology in 2012, I can't remember the month, talked about there's an increase in tumor cells in patients on chronic opioids. So you have cortisol and immunosuppression, decrease of cortisol affecting the reticular activating system. And then you have decreased scavenger cells or macrophages going out and grabbing these aberrant cells. So there's an increase in tumor cells. So if I haven't driven it home hard enough, opioids are not the answer. We still write for them, but America makes up 4.8% of the world's population. We use 80% of the world's opioids that are produced. We use 99% of the world's hydrocodone produced. So I propose this use like, look, okay, it's already obvious that we have a big problem with all these deaths in the U.S. I was talking to a colleague pain colleague from University of London. And I said, "What's the whole take on marijuana out there?" And he goes, "What are you talking about?" He's like, "Me and my colleagues smoke it. Like, what's the big deal?" I'm like, "You guys smoke?" He goes, "Oh, no, we don't smoke it when we're coming to work, just like alcohol. But what is your Americans' big deal with marijuana when your whole country is narcotized?" And I'm like, touche, I don't know what to say. So I bring this all up to you because I'm sure you guys are well aware. We're hearing about this. It's a hot topic, but we need to think about what are opioid-sparing modalities and what we can offer to patients. And that's why I think DRG stimulation is that. So traditional stimulation, we have the percutaneous leads, we have the paddle leads at the surgeon's place. There's a lot of good reasons for doing that. I still think traditional stimulation is good, but we're quickly changing to where we're going to be like Europe and Australia. And we're going to talk about DRG stimulation. And right here is the DRG stimulation. So the dorsal root ganglion, I'll talk more about that. But you can see here we're going out in the areas of where the dorsal root ganglion typically lies right beneath the pedicle. It's actually pretty consistent in its location in the cervical and thoracic and lumbar spine. Sacral, it gets a little bit questionable where it lies. But the dorsal root ganglion is a primary sensory neuron processing point for the patients. As nociceptive, as neuropathic processing that happens in this area. And it's consistently located from person to person, making the targeting reliable and repeatable. It requires 95% less power than typical stimulation. And it's less positional. So one of the problems with traditional spinal cord stimulation, patient lies down, a patient stands up. They have, because of the cerebral spinal fluid in that area, there's issues with the stimulation intensifying and decreasing. There's one company that came out with an accelerometer to try to adjust for that. But really, if you stimulate the DRG dorsal root ganglion for focal pain, and again, that's the indication, really for focal pain, we're able to just isolate. We're not having this issue of stimulation increase and decrease. We're able to keep it pretty consistent. So it targets both focal and broad areas of intractable chronic pain. So there's some doctors in Europe that have shown we put two DRG stimulator leads bilateral at the L2 level, we can get axial back pain. Some have showed that we're able to capture abdominal pain, chronic abdominal pain, a lot better than traditional stimulation. If we put them at higher levels, T11, T12, L1. But the main focus of the study I'm going to talk about is an accurate study. And hopefully this is going to be published in the next couple of months. But specifically looking at complex regional pain patients. And they've also done in Europe peripheral neuropathy, groin pain, abdominal pain. I'll touch briefly on that. Some of those patients actually did make it into the study, which I thought were interesting. This is published in MedTech Insight in 2013. I can get the actual month if you like. I can't recall right now. But they looked at traditional spinal cord stimulation and penetrance of traditional spinal cord stimulation in certain types of pathology. And they found the least penetrated was peripheral neuropathies. So that's a big problem. We can do sympathetic nerve blocks and traditional stimulation, but one of the big problems that we have with traditional stimulation is a lot of time we have difficulty covering the whole foot. A lot of patients come and say, you got the top of my foot, doc, you got my ankles, you can't get the plantar aspect of my feet. And that's really I'm having a lot of my problems with the peripheral neuropathy. So we're working on studies right now in Europe. I think it's going to be level 1 as well. But we have a great success rate in some of these smaller studies of DRG up to 90% for peripheral neuropathies. But I'm going to focus primarily on the accurate study. And this was again presented last year at International Neuromodulation Society and North American Neuromodulation Society. At those, I guess I would say those are the top neuromodulation society internationally and locally. That pain specialists and neurosurgeons and even orthopedic spine surgeons, some neurologists were there. We've given lectures too, some of them lecturing. But this data was presented and it was nothing short of it just blew everybody away. It's level 1 evidence, 152 patients, 22 sites that were used here in the U.S., and we're able to show that there's superiority of DRG stimulation for focal pain, particularly peripheral causalgia, and CRPS type 1 in comparison to traditional spinal cord stimulation. The primary endpoints. So the primary endpoints was 3 months to show 50% relief or better. And at 3 months, we showed 93.3% in comparison to the control was traditional spinal cord stimulation. And then at the end of 12 months, we showed that there was a 74.2% pain relief, again 50% or more, in the DRG patients compared to traditional stem, which was 53%. And so we showed statistical significance at 3 months, and we'll hand all these out. I'm sorry we don't have it actually. Here's the JAMA article, but it still hasn't been published yet. But this is significant, and I must mention that this isn't something that was really, I mean, the industry helped sponsor this, but just like the Cinsa RCT Nevro study that's been blowing everybody away, and even Wall Street has begun to invest in stock with Nevro, it's pretty interesting. St. Jude jumped up $16. I should have bought. I just wish I don't. Anyways, but basically, the Wall Street has gotten a hold of this because for spine surgery and for pain, we haven't had real great evidence. But now in this last year, stimulation, we've had two great RCT randomized controlled trials, level 1 evidence. Well, now if and I don't mean to stand on a soapbox here if you guys are involved with working with some of the insurance companies, but it's so hard for me sometimes because they'll say, well, you don't have any level 1 evidence. Now I do. So all that stuff they're throwing in my face, I was like, look, here we go. I've shown that, and this doesn't show that traditional spinal cord stimulation still doesn't work. That's actually statistically significant as well. It just showed that DRG was better in certain types of patients. So again, custom fitting our approach on what we should do for our patients. One thing I should mention as a side note is that, I'm sorry, let me finish with FDA. FDA rigorously designed study. So this isn't something that St. Jude can come in and kind of botch the numbers a little bit. The FDA, because they're so concerned about safety and making sure that there isn't confusion if there's a high-quality study coming out, they every step of the way, they had to continually be held accountable by the FDA. And so was the Cinsa RCT study, which is one of the competitors of St. Jude. They were also rigorously followed by the FDA to make sure that everything was in compliance and up to their standards. So I mentioned the positional movement showed that 15% of patients in the DRG group, 85% in essence, really didn't have positional changes. And then in the control, there's only 65% that showed that there wasn't positionality. So there's a big difference in positionality. But really the big thing is that we've shown superiority compared to traditional stimulation. So what does that mean? So kind of peeling this back. Again, certain types of pathologies are going to make a difference in comparison to traditional spinal cord stimulation. So again, traditional stim focus on head, back, leg, vascular. So occipital neuralgia, refractory angina used to actually be the #1 indication in Europe for stimulation. Put at the T4 level, can help patients with chronic stable angina. Failed back surgery syndrome, failed neck surgery syndrome, if you will, is the big one that's used here in the U.S. Peripheral vascular disease, all for traditional stim. But we have all these other syndromes that have been more challenging to address with spinal cord stimulation that we can now do with DRG stimulation. So I kid you not, when I walk into my office, it's exciting for me since this has been FDA approved on February 7th. And I was blessed to be one of the guys that actually was involved in the ACURATE study. Some of my patients were enrolled in that study. And my colleague here in town was one of the investigators that he actually took some of my patients and enrolled them. But I've been able to see this be groundbreaking and change patients' lives. Where I walk in and say, Mrs. Jones, she's already had a gazillion revisions of her right knee. She has allodynia. She has swelling. We've tried to do genicular nerve blocks and low temperature radio frequency. We've even, some of them even had traditional spinal cord stimulation. We can do a DRG stimulation to try to capture that, in essence, peripheral causalgia, post-surgical neuropathic pain of her knee. A lot of podiatry patients, a lot of ankle and foot pain, peripheral neuropathy patients, patients that have had hernia repairs, patients that have THAs or total hip arthroplasties. So now I've been able to, these patients where we kind of would try opioids and maybe some neuropathic medications, maybe other types of injections, now we have something that shows that over 12 months there's a significant amount of pain relief. And so let's talk about that. So thoracic neuropathies, post-mastectomy pain, post-thoracotomy pain syndromes. Keep in mind the post-herpetic neuralgia patients. One of the stats here, I don't know if it's still current, but probably about 10 years ago, the #1 cause of death in geriatric populations was suicide, was post-herpetic neuralgia. And so it's just for pain syndromes. Abdominal visceral pain, post-surgical pain of hip, of knee, of foot, of ankle, groin, testicular pain, pain and stump pain, phantom limb pain and stump pain from amputation, CRPS, and again, distally located neuropathies are really, we're able to do focal stimulation for these patients. Again, in the context, if it's an opioid sparing modality and they've already failed conservative things, I think we should try DRG stimulation. I just had a patient that had multiple surgeries on his right foot. He has allodynia, he has a lot of issues. Just got online, saw that I did this lecture, said, I want to come down to Arizona and get this stimulation. Real excited for me, not sharing the story because I'm, I'm trying to say that I'm special. It's just exciting because people are not just getting a hold of this locally in Arizona, but outside the states are realizing, well, there's only a couple docs right now that have been improved. We're hoping to increase that amount of physicians over time. Things the FDA, again, highly regulated, said that you have to have 14 hours of cadaver training before you can start doing this on patients. But I'm just saying it's impactful. Patients are really coming to us in high numbers, wanting to see these things that they've been dealing with for years and kind of just been like, take your Percocet, take your gabapentin, take your Lyrica. Now we have something I think that can answer those issues. So I always say to my fellows and my medical students, don't be like some of our friends in Scottsdale. I don't know who's. Sorry, I hope this isn't one of your guys' car. But just always work hard and be humble is what I always tell everybody. I just can't believe that the 1%. That was pretty funny. But go ahead and hit the next one, Jill. So any questions? There's my cell number. There's my email. Any questions about this?
So 2 questions. What about DRG for notalgia paresthetica, which seems would be a wedding, and thoracic outlet syndrome?
Thoracic outlet syndrome, I haven't heard. The first one, I have heard some docs getting relief for that. If you can identify a nerve that has a source, it's been actually very successful. So, and then another one's genitofemoral neuralgia, iliohypogastric neuralgia, inguinal neuralgia. So these things, neuralgia paresthetica. Thoracic outlet syndrome, have you heard anything on that one?
I haven't heard it. I think that's actually a really interesting idea, though. It's a great concept. I mean, that's a tricky one because we don't even know what causes it. Right. But you have to assume it's a neuropathic condition, whether it be nerve stretching or what it might be. I think it's a fantastic idea. Right now, the FDA has approved us in America to do this device from T10 to S2. So in Europe, they're doing it everywhere.
See,
Yeah.
that's why I asked about notalgia paresthetica.
Oh, I'm sorry. I thought you said neuralgia paresthetica. Yeah.
Notalgia paresthetica, which is due to, we believe, inflammation of the thoracic dorsal root ganglion. People have pain about that size of an area, just medial to the scapular border. So
Yeah.
I've never heard of that. What is it? Notalgia?
Notalgia paresthetica.
Right.
Yeah, people will come in the medial border of the scapula. People have burning and they keep scratching their back, and it's just
Interesting.
described.
Much to my chagrin, I think I've had patients like that. I've just said, oh, it's a shoulder. Wow.
It's actually first in the United States Navy periodical.
And it's
Was
from the
first-
DRG.
Was the first, it is.
Yeah. I think if it is DRG and then
The dorsal root ganglion about T4, T5, T6 of that area. People will just scratch their mid-scapular
Interesting.
area and it'll burn and hurt. There's no winging of the scapula. It's not a spinal accessory nerve problem, but it's well prescribed in the literature. So
Interesting.
Notalgia.
I know guys have done DRG all the way up in the cervical area, so I wouldn't be surprised. It's interesting. We're part of there's probably about 40 docs in the country, 50 docs in the country that have been approved to do this. And we have a forum that we're all on because this is exciting. We're starting to see patients that just haven't had relief for literally decades. And that's what I want to probably put on here and say, hey, what do you guys think? And yep. Yeah. Yeah, I think that's a great idea. We'll put that because we have Barani, who is one of the, hey, Dr. Crooks, thanks for coming. No, we're still talking about it. That's what's exciting. So as you know, for postherpetic neuralgia, that the virus resides in the nucleolus of the DRG. That's also wetting that we've been told about our European counterparts. The challenge is that because the FDA approval is in the lower regions, we could do off-label, and we do all the time. I mean, you think about it. Steroids are off-label for epidural steroid injections. That we can do it, but they're recommending St. Jude's. They really want us as this rolls out to kind of stay on label. But I could put on the forum because I bet you that there's someone in Europe and Australia. I mean, it's been in Europe and Australia. What's it, about 4 years, Joe?
4 years.
So 4 years in Europe and Australia. It was so cool at Barani, another one, Vic Patel, Stefan Shu, several of these guys, neurosurgeons and pain guys, have been doing this. Fitzgerald at Oxford, a lot of these different ones have been doing this, and they're just discovering stuff all the time, specific focal pain that they're able to hit. And I wouldn't be surprised if one of them has some input on that.
So tell me about the procedure. If I have a patient in my clinic tomorrow, and I'm thinking, wow, DRG, what do I tell them? How often does it occur? How long does it last? How many visits to you guys? Tell me about the procedure.
Yeah, absolutely. I'm sorry. And then we're going to go through some case vignettes of different patients, but I'll tell you about the procedure. It's just like spinal cord stimulation in the sense of placement. So what I tell my patients as an anesthesiologist, also pain doc, but anesthesiologist, when someone's getting epidural for pregnancy, I mean, there's millions of women that get epidurals every year, and we do that. We come in the room, we place a small needle, and through that small needle, we place a tube that delivers medications to the lumbosacral region. Well, spinal cord stimulation, I kind of say it's like a pacemaker for pain, affecting the dorsal root ganglion, affecting the dorsal column, but now also affecting the dorsal root ganglion. So it's an epidural placement. What I tell my patients, spinal cord stimulation, we go epidurally, just like we would for an epidural for pregnancy, but instead of placing a small tube that delivers medications to bathe those nerves in the lidocaine and the morphine or whatever we inject, we're delivering stimulation to the nervous structures there, so that it's really not much different. In fact, the needle size is about the same, and it's I think safe. Well, I think a ton safer because one, they're not in labor, they're not moving around, and we're not doing it blindly. When we do epidural for pregnancy, as you probably know, they're leaning over, and you're just going in there and feeling. I have a fluoroscopy machine. I know exactly where I'm placing the needle, and so that's how it is for a spinal cord stimulator. So I place this epidurally, and I place the leads in an appropriate location, and be the same exact thing for DRG stimulation. So I tell the patient, hey, look, we're going to get near your areas. So let's just say it's somebody with foot pain. So usually, what's nice about the DRGs, what we discovered is we read about it, we studied about it, but just also clinically, there's a lot of redundancy. So we've had patients where we go in the L4-5 level and do the L4 DRG, and we're able to get the whole foot covered. But often we'll place L5-S1 in that DRG area, and then L4. Sometimes we'll do L3, and that can cover the foot, but we'll focus on one or two leads placed, and McJunkin will show pictures of this. But it's the same exact placement. It's a little more technical in the placement of the leads, but I would just say it's like a spinal cord stimulator trial. So all patients that get a spinal cord stimulator trial, I'll tell them, look, you're going to get to test drive this pacemaker for pain. You're not going to have any metal put in your back except these soft tubes. We'll remove the needles. We'll tape it up. It's just like a test drive a car. I'll throw you the keys, and for 5 to 7 days, you get to see if this device helps your pain. And so during that time, I'll tell them, hey, we're going to reprogram. We're going to turn the device up, turn it down, turn it off, just use different types of programs. And basically, I'll pass this around. Here's an example of the DRG lead that we placed right over the DRG. And they'll go home with the trial. And the trial is really going to answer the question, this is the right fit. I could quote all the data, and I can do all this great stuff. And this, don't get me wrong here, this isn't the panacea of all things pain. It's not the magic bullet. But I'll tell you what, for focal pain, it's coming pretty damn close, and it's pretty exciting for us. So for neuropathic chronic pain, that's refractory pain, that's focal in the realm of CRPS or peripheral neuralgia or peripheral causalgia, if there's an identifiable nerve that's injured, we can do DRG stimulation for that. And so if they get a successful trial, greater than 50% relief, usually we try to look for, hey, was there a decrease in medications? Was there increase in function? We had just one that we did last week. The lady had really terrible lower abdominal pain, groin pain. She was able to walk around the block for the first time in years. And she just had so many abdominal surgeries, and we're able to cover that area. But to answer your question, if they have a successful trial, then we'll implant a small IPG battery, just like traditional spinal cord stimulation. And the biggest thing that I can't stress more is that we don't, I recommend, this is based on a Kumar study on neurosurgery for traditional stim. I think this also applies for DRG stimulation. The longer we wait to get the patient exposed to stimulation for the chronic pain, the less likely they'll be a responder. Now, we had patients enrolled in this study that had pain for over 10 years. I think Kumar looked at 18 years for traditional stim, but it's important, and again, in the context of what else do we have to offer, well, people are like, well, this is invasive. I go, I'll tell you, the most invasive thing that we're probably doing for patients is writing for opioids. I hope I kind of drove that point home earlier. But again, if it's an opioid sparing modality, I think we should try it. And more importantly, it's exciting now. The handful of patients that I've been involved with, it's been nothing short of exciting for us. This lady, 8 out of 10 pain, went down to 2 out of 10. McJunkin, you had a CRPS lady's foot and ankle. What were her VS scores that you saw during her trial? She went 10 down to 5. There's other docs that have seen 8 down to 10, so at least 50% relief. But if it gets them off half their opioids or they're able to decrease their medications, I think it's worth looking at, especially because what other answers do we have? I do think that stimulation is still in its infancy. I think we're going to come out with more things as we go down the road. But that's where we're at, and it's level 1 evidence, so that's what's exciting about it. Is this MRI compatible? Okay, so it's not MRI compatible. Not yet. So to answer your question, if you were at the Cleveland Clinic, they would say nothing, and they would just scan the patients. So it is a little silly. I know, Doctor, and this is all off-label, but since he asked, it is. You have an MS patient. You have somebody that's so it's a very salient point. Traditional stimulation, there are MRI for limb and for head. There are MRI compatible systems. Right now, DRG, we're kind of taking what we can get. It's going to be developed more, but it just depends. I mean, you can still get obviously all other types of stimulation, particularly MRI. Right now, DRG is not. We can't get the Valley Radiology and the Simon Med largely because of the labeling. Now, this is so hot off the press. I don't know. I don't want to be disingenuous. I know for traditional stim at the Cleveland Clinic, they are doing, for regular stimulation, they are doing MRIs. But I don't know about DRG stimulation. This is so new. I don't know if they're doing it or not. But yes, this is a big challenge. So what I tell my patients is this. I have patients say, well, what if I need an MRI down the road? And I'm not talking about someone that has something that we need to get serial MRIs for, things like that. Clearly, there are systems out there for traditional stim that have MRI compatibility. Some of them are conditional, some of them are full MRI compatible. But I will say this, we are able to remove it. So I had a lady that came back, they were pretty confident that she had hemochromatosis, and this wasn't DRG, this is traditional stim, and we explanted the system. It is reversible, it's not an end-all be-all. If you get the system in place, you can't have this removed. But if they come to the push comes to shove, they have to have an MRI, then we can remove the system. No.
So is the DRG run by a battery?
Yes, it's ran by the IPG, which is an internal pulse generator. We say it's like a pacemaker. Do we actually have a battery?
How long does it last?
Typically it lasts 5 to 7 years. It's rechargeable, and some of them are non-rechargeable. Is it primary cell only, or?
That's primary cell, and that's the pre.
Oh, so in the U.S., they're actually doing primary cell because, as I mentioned earlier, 95% decrease in battery usage. So we're finding that their primary cells are actually lasting just as long as the rechargeables. So they're like, look, if you have a battery that lasts 5 to 7 years and it's a primary cell battery, then we don't need to necessarily have a rechargeable. And we found in Europe patients like that. So the rechargeable option, is it going to be available or is it not available right now? And I'm sorry, Derry. This is so hot off the press. Some of this is new for me. So. Okay. So let's just pass this around.
You know, patients just ask these questions.
Oh, no, absolutely. And so we put this, typically, you can put them where you put a regular pacemaker. Some of the docs place them here, some place in the abdomen. What we've found to have the least complaints is here in the back, just above the iliac crest and below the 12th rib. Yeah.
And that's also a bigger version of the battery than what will be, because this is really just launching. So there's going to be
Yeah, it's pretty.
To make it thinner,
Yeah.
thinner, smaller.
It's actually smaller than the traditional stimulator batteries. But again, and I know you guys probably don't write for a lot of opioids, but we have docs come in, they're writing for 200 morphine and some sort of oxycodone equivalent. I'm like, look, okay, again, what's the risk of doing something versus the risk of doing nothing and just are continuing to write for opioids? I would say we're in such a big we're in the throes of an epidemic. They're saying last year it might be 20,000 deaths. We have ceased to continue to increase every year. So we've gone from 15,000 to 17,000. Last year they think it was 20,000 deaths related to opioids. And again, this isn't all things pain. This isn't all things stim, but in the properly selected patient, I think we have the potential to get them decreased in their opioids or off. I think it's worth exploring that option. And the trial is really what's going to answer the question. I think that's the biggest thing. I say, look, I don't know if this will work for you. It's always very disappointing. We had another patient. We got great coverage of her foot. We got all this paresthesia of her foot, and she's telling me right now, she changed her mind now? I don't know if I buy that. And she says but the thing is, this is actually really sad. She's on a lot of Dilaudid, and all she could talk about is, I need more Dilaudid. I'm like, look, we're covering your foot. You just had a small needle go in your back. And she's like, I don't know if it's covering my pain. And so I think we might be dealing with some other confounding variables here. Unfortunately, I think she might be hooked on her opioids.